Dr. Natalie Hundt, come on up, Dr. Hundt, is a clinical psychologist at the Michael E. DeBakey Veterans Affairs Medical Center. She's an assistant professor at Baylor College of Medicine and a current recipient of a VA Career Development Award. Dr. Hundt conducts research regarding factors associated with low engagement or dropout from PTSD treatment, which will inform the VA's efforts to increase help seeking in veterans with PTSD. All of these researchers are very well qualified and have long biographies, so when this is done, please go online and you'll be able to see their presentations and their slides and read about some of the amazing things they did. Dr. Hunt?
Thank you. So I am talking about a couple different research projects that we've done, all about engaging veterans in PTSD treatment. And so the first thing that we should know is that we do have effective treatments for PTSD. As a psychologist, I'm probably a little bit biased towards the therapy option, but we also have effective medications for PTSD. And as far as the therapies go, there are two what we call evidence-based psychotherapies. So that means that we have can you guys hear me okay?
Yes.
Okay, thank you. So when we say evidence-based psychotherapies, we know that there has been, decades of work showing that these psychotherapies really help with PTSD. And those two therapies are prolonged exposure and cognitive processing therapy, and they're both what we call cognitive behavioral therapies. So they're more kind of structured therapies. They have homework assignments each week, clear collaborative goals set with your therapist, and keeping track of the person's progress in therapy in order to make decisions about care. And both of these therapies are about 12 to 15 sessions of therapy, and the sessions last about 60 to 90 minutes apiece. So knowing that we have effective therapies that have been used for decades and have helped veterans and civilians with PTSD for decades, my question for you is, what's the biggest problem that we have in PTSD care? And I think you can tell from the title of my talk what I think the biggest problem is. So the answer, in my opinion, is just getting veterans in the door in the first place. And this is research that we published in 2014. So this is a national VA database. So in 2010, we had 165,000 veterans newly diagnosed with PTSD in that year within the VA. And of those, 56,000 had any therapy appointments in the year after their diagnosis. So less than a third of them got even a single therapy session. And then of those veterans, only 14,000 completed 8 or more sessions of therapy. There's nothing magical about 8 sessions of therapy. We just sort of make that as a reasonable cutoff for at least 2 months of weekly therapy. So that shows you that less than 10% of veterans were getting what we consider to be sort of a minimum reasonable dose of therapy. And then over there in the other little bubble, if you can read that, it says, and how many more never diagnosed? So these are the ones that we have identified, but we have, of course, no idea about the veterans who never come to VA at all, or who come to the VA only for primary care and pretend that everything is fine. So the question then becomes, why aren't veterans with PTSD getting the treatments that work and the treatments that can help them? And so when we talk about barriers to care, we look at 3 different types of barriers. We look at patient barriers. So patient barriers could be things like the veteran is simply too busy between work and childcare and family to make it in for treatment. But they can also be things like attitudes about therapy, right? So, that won't be able to help me, or, it would be too embarrassing to come to therapy. We also look at provider barriers. So provider barriers could be things like, the provider's schedule is too full of other patients to be able to fit more people in. Or it could be maybe the provider's having difficulty kind of connecting and building rapport with the veteran. And so that makes the veteran more hesitant to come in. And then we also look at things like clinic barriers. So clinic barriers could be things like maybe the clinic is disorganized and loses referrals and people slip through the cracks, or potentially things like not having weekend or evening appointments that make it convenient for veterans to come in whenever they're able to come in. And so when we look at the research, we really need to look at all three of these types of barriers. And I'm going to be talking about a couple of them as I go through these slides. And the first one is about capacity to deliver PTSD care. So this is from a paper that we just recently published, and this is data from the Houston VA itself. And so you can see on the left-hand side of the graph, in 2008 to 2012, only 11% of veterans in our PTSD clinic were receiving evidence-based psychotherapy, those two therapies that have really been shown to work. But by 2015, we had gotten that number up to 54%. So that's a more than fourfold increase in just a few years. And we can go into all the kind of clinic changes and transformations that the VA has done to make this happen. But I think that's kind of beyond the scope. But basically, we have been changing things in the way that we operate in order to get more veterans into psychotherapy. But one question that remains is delivering these evidence-based treatments to which veterans, to whom? And so part of our research has also shown veteran characteristics that make them more and less likely to engage in psychotherapy and in evidence-based psychotherapies. So you can see on the left-hand side of that graph, the veterans who are more likely to get evidence-based PTSD therapy are those who are married or living with a romantic partner. So probably because the partner's the one kind of elbowing them like, hey, you need to get some help. And also veterans who are service-connected for PTSD are more likely to get evidence-based treatment. Part of that may simply be recognition that there is a problem in the first place, and part of it may be financial, because being service-connected for PTSD helps you get free care for that PTSD. And then over on the right-hand side, we've also done some research showing veterans who are less likely to get evidence-based PTSD therapy. And those are veterans who have a substance use disorder, and also the more complex cases, so folks who have multiple different psychological diagnoses along with their PTSD are less likely to get evidence-based care. And that may simply be because they have a lot going on, and it's difficult to figure out what to start with in terms of their care. And then the next thing that we have looked at is, if you want to know why veterans aren't seeking care, well, probably the easiest way to get the answer to that is to ask them. And so we have been doing a qualitative research over the past couple years. So qualitative research is where you just sit down in a room with a veteran and ask them a bunch of questions and just see, what they have to say about their attitudes towards psychotherapy and their experiences in seeking mental health care, both in the VA and outside the VA. And so we are still recruiting for this study, actually, but so far we have interviewed 23 veterans who had completed one of those evidence-based therapies at the VA. 17, actually it's 18, we had another one yesterday, who dropped out after starting therapy, and then 22 veterans who were diagnosed with PTSD but refused to start therapy at the VA, even though they were offered that therapy. And we made sure to recruit veterans who were diverse in terms of race and ethnicity, gender, service era, trauma type, so for example, combat versus military sexual trauma. And we asked them all kinds of questions. I'm going to be presenting a very small slice of the data that we have today. So the most important thing I think that we asked them is, what held you back from getting treatment, or what concerns did you have? And so a lot of folks talked about anxiety about seeking therapy. So having to talk about their traumatic experiences with a therapist, being worried about what that would be like, being nervous or embarrassed. And I'm not going to read all of the quotes because I think you guys can read them up here on the slides. And then also folks talked about the belief that ignoring the trauma or blocking it out was helpful. So I think for a lot of folks, the initial reaction is, I'm just going to pretend that didn't happen. I'm going to block it out of my mind. I'm just going to move on and try and live my life and hope that it goes away. So this veteran, for example, he said, leave it alone. Don't trouble, trouble won't trouble you. And that was one of my mother's greatest sayings. And so for him, it was this idea of coming to therapy and dredging this up again. He wasn't sure if that would be counterproductive or whether it would be helpful. For other veterans, there was skepticism about whether the therapy could work. So a lot of folks are unaware that there is a lot of research to support these therapies. And sometimes the therapies seem a little bit sort of confusing to veterans, I think, and to non-veteran patients as well. So this veteran was saying, you know, when my therapist explained the therapy to me, I thought it was BS. I thought, you're crazy. Like, that's not going to work for me. So sometimes it's this negative reaction to what we're asking them to do in therapy. There's also a big problem with lack of knowledge. So veterans simply not knowing what is out there in terms of treatment resources, not knowing that there's research support to these therapies. So this quote is from a veteran who actually heard about one of these therapies from another veteran, and he said he didn't know about this